what treatments are available for BPDCN?
I'll divide it out into maybe three aspects. So historical, maybe current, and then future directions. Historically, because BPDCN was a not understood, misunderstood, sort of rare elusive entity, it was sort of treated, and I think appropriately so at that time, as what was the biological understanding at the time. For example, if you look in our historical literature, if it presented as skin predominant, folks gave skin directed therapies, including maybe even topical. Those largely did not work, as the disease would come rip roaring back as a marrow disease, leukemia, and ultimately fatal disease. A second aspect of historical therapy was systemic therapy, usually multi-agent chemotherapy, usually borrowed from the existing more common blood cancers. So just to give a quick example to some of the viewers out there that know this program well, multiple myeloma therapies, which have been around for a while. So that's been used in BPDCN to varying degrees of success. ALL, acute lymphoblastic leukemia protocols, AML, acute myeloid leukemia protocols, lymphoma protocol, so on and so forth. So the basic theory is it's an aggressive disease with poor overall survival, as I just mentioned, less than a year, multi-agent chemo, potentially CNS penetrating, et cetera. Unfortunately, those had mostly suboptimal outcomes, and again, usually older, frail patients who are susceptible to infection, sepsis, multi-organ failure. Then as you move more into the current era, I think we have this emerging story, which I've been fortunate to be the world leader in, which is CD123 targeted therapy. Kind of an amazing story in this rare disease. Poor overall survivals with cytotoxic, kind of generic general therapy. The major finding was that CD123, which is a protein surface marker, IL-3 receptor alpha, is expressed ubiquitously. So 100% of BPDCN cases should have it, should be attractive for therapeutic, pharmacological, chemoimmunotherapy targeting, but we didn't have a drug until the one you mentioned earlier, which is TAG or tagraxofus. So this DT-IL-3 molecule serves as a homing device, if you will, that takes a truncated or modified diphtheria toxin payload, infuses it to a human IL-3 recombinant version, and then this is then IV injected into patients, and then it will home to the receptor site for IL-3, which is CD123, IL-3 receptor alpha, thereby causing directed damage to the BPDCN CD123 bearing cells. Well, this was a breakthrough because what we were able to do in frontline patients, as well as even relapse refractory, is have a very high response rate, ultimately getting the drug US FDA approved in December of 2018, ages 2 and older, so including the majority of pediatric patients. And then ultimately, even in the EU, European Association, in January of 2021 for adults with BPDCN. So that marked a major milestone that offers a new, modern, if you will, the first targeted therapy for just BPDCN, the first ever drug approved just for this rare indication. There are other CD123 therapies actively in clinical trials. The next one that's in the latest stage of development is that of pivekimab sunirine, or IMGN 632, which I have presented publicly a couple of years ago as a positive phase 2 clinical trial at the EHA meeting in Frankfurt, Germany, a year or two ago. And so we await those trial data to mature. Outside of these two CD123 agents, there's a number of other molecules that have been tested and are being tried, bispecifics, CD123 monoclonal antibodies, and CAR-Ts. Outside of that, there is the venetoclax agent, which our group and others have shown activity. This is the anti-BCL2, which has already been approved in AML and lymphoid malignancies. And again, either as a single agent or in combination with CD123 and other chemotherapy has showed benefit for a number of our patients. And then finally, as we think about future directions, we're starting to test formally in the clinic triplet combinations. So CD123, BCL2, and chemo, ALL-based chemo, for example, and then CD123, BCL2 targeted, and then hypomethylator, either AZA or decitabine. And those are active ongoing clinical trials that folks can look up online. Finally, I want to mention stem cell transplant, a huge important part of this disease thus far. As in many other aggressive myeloid malignancies, transplant in what we call first CR, first complete remission, appears to be the way to go. We've done a limited number of autologous from the patient themselves only cell transplants, but the majority of what we're doing and have done is allogeneic stem cell transplant, a donor from someone else to the patient. Finally, I have to mention CNS prophylaxis and CNS treatment. The vast majority of patients who will have CSF positivity and then BPDCN will be asymptomatic. That's a good thing. So usually we can treat with intrathecal chemo to reduce that and go back to negative. But a small fraction of patients will have symptomatic disease, so we try to catch that early, as I mentioned. And if it needs treatment, triple intrathecal chemo for the spinal taps, and then radiation and other things, if and when needed. That's a small fraction of the cases. Finally, I'd like to also mention there are a number of active clinical trials ongoing, both here at MD Anderson, across the US and across the world, that are either trying to test novel targets that I have not mentioned here, or different combinations of therapy, ALL-based and others, either with the newer agents or with older agents. Again, the goal trying to be to eradicate the disease before it gets to the relapse refractory setting, or once it's already there to treat it.
So it can be treated in different ways. I'm not sure that there's a firm standard of care way of treating it. I think what is attractive in 2025 is targeted therapies like tagrexofusp, the anti-CD123 directed diphtheria toxin. So that's an immunotherapeutic approach. Historically, we've used combination chemotherapies, like combinations like hyper-CVAD, and also we're now increasingly seeing rational therapies like hypomethylating agents plus BCL2 inhibitors like venetoclax. So there are different ways, and I think you tailor the treatment depending on the patient profile and their ability to be able to handle intensive therapy versus less intensive therapy. So there's a lot of factors about the patient, not even just the disease, that might influence the decision making.